Welcome to the deep dive. If you're getting ready for a clinical rotation or maybe just want a faster path to clinical excellence, well, this is your shortcut. Today, we're diving deep into something really fundamental: pediatric skin and tissue integrity. It's a huge area in nursing practice. Our source material actually uses a couple of great metaphors. It says the child's skin is life's gift wrapping, but maybe more importantly, to the child, the skin is the spacesuit for life.
Yeah.
And that is our focus today, protecting that crucial barrier.
Exactly. And that really sets our mission for this deep dive. We need to go beyond just defining things. We'll compare those key biological differences between kid skin and adult skin, lay out the nursing assessment process step by step, and really zero in on managing common skin issues.
Yeah.
Infectious, inflammatory injuries, all specifically for children.
Okay, let's jump right in then. If the skin is the spacesuit, what are the weak points in an infant suit? What makes it so vulnerable?
It really boils down to two things:
Yes.
immaturity and permeability. An infant's epidermis is just way thinner than an adult's, and they have very little subcutaneous fat. This means blood vessels are much closer to the surface.
Okay.
And that thinness leads to, well, three really critical consequences you have to remember. First, they lose heat dramatically very quickly. Second, bacteria can get in much more easily. And third, maybe most critical for nursing, substances applied to the skin get absorbed far more readily.
Wow. Okay, so the big takeaway isn't just thin skin. It's that even a mild topical cream could potentially become a systemic toxin. That changes everything.
Precisely. That dictates so much about what we prescribe and how we apply things. Plus, infant skin has more water content, and the epidermis isn't bound very tightly to the dermis underneath,
Good. Yeah.
meaning friction like from a diaper that doesn't fit quite right or even rough clothing can cause those layers to separate really easily.
Well,
That leads to quick skin breakdown, blistering.
okay.
And another thing, young skin, no matter the child's background, has less pigment. So the risk of UV damage is way higher.
And this vulnerability lasts for quite a while.
It does. These characteristics don't really reach adult levels of resilience until the late teenage years.
Now, the source mentions specific things to look for when assessing children with darker skin tones. What are some key differences we might see?
Yeah, that's important. You might see more pronounced reactions, cutaneous reactions, and changes after healing are common. Things like hyperpigmentation, where an injury or inflammation was. That's pretty frequent.
Right.
You'll also often see more prominent papules, maybe stronger follicular responses, sometimes vesicular or bullous reactions. And a really serious consideration for kids with darker skin is a higher likelihood of developing hypertrophic scars or even keloids after an injury or surgery.
Good to know. Okay, let's shift gears slightly to gland development. This obviously sets the stage for adolescent issues like acne. How do those glands mature?
Well, the sebaceous glands, the oil producers, they ramp up sebum production during predolescence and adolescence. That's directly tied to the hormonal changes that trigger acne.
The dreaded acne.
Indeed. Then you have the eccrine sweat glands, the ones for temperature regulation. They don't actually become fully functional until middle childhood.
So infants aren't great at cooling themselves down.
Exactly. Their thermoregulation is less effective before then. And the apocrine glands, the ones linked to body odor, they only mature and kick in during puberty.
Okay, so if this spacesuit is fragile, how do we systematically check it? Let's talk about the nursing process. You mentioned that assessment is vital because sometimes a rash is the first clue to something serious going on systemically. What history questions are essential?
Right. Beyond just the main complaint, maybe itching, scaling, or how it looks, you need the details of the present illness. Get a timeline. When did it start? How long has it been going on? Where exactly is it? What does it look like, feel like? Are there other symptoms? Fever, feeling unwell, and critically, what makes it better or worse?
Okay.
And always ask about recent changes, new foods, new soaps or detergents, new pets. Any family history of allergies or eczema?
Got it. Then moving to the physical exam, describing what we see accurately is key. Instead of just listing terms, what's a critical distinction we need to make when describing lesions?
Good point. First, you need good light. Natural daylight is best if possible. The most critical descriptions differentiate between lesions that are flat, solid, or fluid-filled. You absolutely have to distinguish a papule, that small, raised, solid bump, from a pustule, which is similar but filled with pus.
Okay, papule versus pustule, clear difference.
Yes. Also, note the pattern. Is it annular, like a ring with clearing in the middle? That screams ringworm. Or is it linear, in a line? That often suggests something external made contact, like scratching after poison ivy.
What about diagnostic tests? Which ones are most common and what do they tell us?
Okay, three really stand out. First, the KOH potassium hydroxide. If you suspect fungus, you pretty much have to do this. It lets you see those branching hyphae under the microscope.
Right, confirms fungus?
Second, IgE levels. They're often high in allergic conditions like eczema, but it's not specific. Lots of things can raise IgE. Still helpful context, though.
Okay.
And third, the CBC with differential. Specifically, you're looking for elevated eosinophils. That's a classic finding in atopic dermatitis or eczema.
All right. Let's spotlight some nursing interventions now. For impaired skin integrity, say in a child who can't move much, what tools and goals are most important?
For assessing risk, you need a pediatric-specific tool. Use something like the modified Norton or Braden Q scale. That helps you track the risk systematically.
Makes sense.
Physiologically, nutrition is huge. Making sure they get adequate intake is just non-negotiable for immune function and healing. But if the biggest risk is fluid volume deficit, which is absolutely critical in burn care, then the highest priority becomes strict, frequent monitoring.
And what are the gold standards for monitoring fluid status in those really high-risk kids?
Strict as an O's, definitely. But the best single indicator of overall fluid status, daily weights. Same scale, same time, every day. And your clinical target, especially after a burn, is urine output of 1 to 2 milliliters per kilogram per hour. That's 1 to 2 ml/kghr.
1 to 2 mils per kilo per hour. Got it.
Yeah, if it drops below that, you need to act fast.
Okay, so assessment's done, baseline set. Now, inevitably, we encounter breaches in that barrier. Let's talk infections, starting with the common bacteria, staph and strep. Impetigo, that classic honey-colored exudate.
Exactly. It starts as papules, then turns into vesicles, then pustules that break open and crust over with that characteristic look. For nursing care, teaching families the right way to manage it is essential. What do you think is the most common mistake people make when applying topical antibiotics for impetigo?
Maybe just putting it on top of the crust without cleaning it first, assuming it'll soak through.
You got it. That crust acts like a shield. You have to teach families to soak the area gently. Cool compresses work well to loosen that crust before they put on the antibiotic ointment.
Okay, remove the barrier first. Makes sense.
Now, for a deeper infection, cellulitis, that localized redness, pain, warmth, we need to be thinking about potential progression.
Especially around the eye, right? Periorbital cellulitis.
Yes, exactly. That often needs IV antibiotics, usually cephalosporins, pretty quickly. But here's a really high-stakes clinical alert. You must notify the provider urgently if you even suspect it's progressing to orbital cellulitis infection behind the eye.
What are the signs for that?
Look for redness in the conjunctiva, any change in vision, pain specifically when the eye moves, or proptosis that's bulging of the eyeball. I remember a case. The only early sign was that pain with eye movement. Recognizing it bought critical time.
Wow, important distinctions. We should also mention CAMRSA risks, turf burns, sharing towels, sports teams, daycare.
Definitely. Now let's switch to fungi tinea. For tinea capitis, scalp ringworm, that treatment is long. 4 to 6 weeks of oral griseofulvin. What's the biggest challenge for families with that?
Just sticking with it for that long, I imagine.
That and the fact that tinea capitis causes hair loss and it grows back slowly. So yeah, compliance over the long haul is tough. Making sure they take it consistently, often with fatty foods to help absorption. The selenium sulfide shampoo helps, but is the oral med that cures it.
Okay. And differentiating diaper candidiasis, that yeast rash, from regular diaper dermatitis.
The key finding, the thing that points you towards yeast, is the presence of satellite lesions.
Satellite lesions.
Yeah, those little individual red spots scattered outside the main fiery red rash area, often tucked into the skin folds. If you see those, think yeast. That needs topical nystatin, not just a barrier cream.
Got it. Satellite lesions equals yeast. All right, moving from infections to chronic inflammation. Let's start with diaper dermatitis, the non-immune type.
Right. This one's more about chemistry, really. When skin's exposed to urine and feces for too long, the pH goes up. That increased pH activates fecal enzymes, which then break down the skin rapidly.
Ouch. So prevention is really the name of the game.
Absolutely. Frequent diaper changes, using those barrier creams, zinc oxide, petrolatum to protect the skin. Now, here's a really crucial safety point. You must strongly discourage parents from using baby powder.
Why is that?
Because inhaling talc-containing powders is a known risk factor for aspiration pneumonitis. It's just not worth the risk.
Wow, okay. No baby powder. That's vital info. Now, on to atopic dermatitis, or eczema. This is where the psychosocial impact really comes into play, isn't it?
Oh, absolutely. It's so much more than just a skin condition. That chronic, intense itching leads to the horrible itch-scratch cycle. It disrupts sleep, makes it hard to concentrate. Imagine the inflammation is like fuel on the fire. Scratching makes more inflammation, which makes the itching even worse.
Ugh, sounds miserable.
It is. And it can cause real psychological distress for kids and teens, affecting self-image and everything.
So management has to focus on hydrating the skin and somehow breaking that cycle. What's the best way to handle bathing?
You have to get rid of all the potential irritants first. No super hot water, definitely no perfumes or dyes and soaps or lotions. Bathe maybe twice a day in warm water. But the key is what you do immediately after.
Okay.
Pat the skin dry gently, leaving it slightly damp. Then right away, apply any prescription topical creams or immune modulators. Follow that immediately with a thick, bland, fragrance-free moisturizer. Think Vaseline, petrolatum jelly, Eucerin, something like that. Lock in the moisture.
Seal it in while it's still damp?
Exactly. And to physically stop the scratching, keep nails trimmed super short, use cotton clothes and sheets. Antihistamines might help at night, mostly for sedation. And for older kids, you can even try behavioral tricks, like using a little clicker counter to help them become aware of when they're scratching without thinking.
Interesting. Okay, we also touched on psoriasis, the chronic immune thing. What are the key visual signs nurses need to recognize?
Right, psoriasis involves the epidermis growing way too fast. It usually shows up as these red, raised papules that merge into thicker plaques. You often see it on the scalp, elbows, knees, genitals. The classic look is that silvery or yellowish white scale with really sharp, well-defined borders.
Silvery scale, sharp borders.
Yep. And sometimes, though you might not test for it often, there's the Auspitz sign, tiny pinpoint bleeding when you load off a scale.
Okay. And before we move to injuries, let's quickly cover contact dermatitis like poison ivy.
Sure. That's a cell-mediated response. The rash doesn't show up right away, usually 24 to 48 hours after contact. Prevention is obviously best long sleeves if you're near it, and washing really well with soap and water within like 10 minutes if you know you touched it.
Good tip, wash fast.
Yeah. There's even an FDA-approved barrier product called Ivy Block. For treatment, it's usually topical or sometimes systemic corticosteroids for bad cases. Tepid baths, maybe with colloidal oatmeal, can help the itching. But here's a really important caution. Never use topical antihistamines, benzocaine, or neomycin on contact dermatitis, especially poison ivy.
Why not?
Because they can actually sensitize the skin, making the person allergic to those ingredients down the road. Big risk.
Okay, noted. Avoid those topicals.
Hmm.
All right, final section. Injuries. Starting with acne vulgaris, which can be a significant psychological injury for teens.
Absolutely. Acne starts with androgens, boosting sebum production. Then skin cells shed abnormally, forming a comedone. That plug traps bacteria, specifically P. acnes, which triggers inflammation. And that connection between severe acne and things like low self-esteem, depression, body image issues, it's very real.
So managing the emotional side is just as important as the skin treatment.
Totally. Providing that support is critical.
And for the really tough resistant cases, there's isotretinoin, but it comes with major safety requirements, right? Especially regarding pregnancy.
Yes, that's the IPL-EGJ program. It's a strict risk management program. For any female patient who could become pregnant, it's non-negotiable. It requires 2 different forms of effective contraception, monthly negative pregnancy tests, and check-ins with the provider every single month because the risk of severe birth defects is incredibly high.
Okay, very serious stuff. Finally, let's tackle burns. The source points out that kids under 5 are at the highest risk, and most burns in that age group are scalds. Classification is important, but let's dig into the fluid shifts. What actually happens physiologically?
It's dramatic. The burn injury causes a massive, rapid increase in capillary permeability. Think of the tiny blood vessel wall suddenly becoming super leaky, like going from a fine sieve to a wide mesh net.
Okay.
So fluid, electrolytes, protein, everything just pours out of the vessels into the surrounding tissue, the interstitial space. This causes huge, rapid swelling edema that can be 5 to 10 times greater than in uninjured skin. And it usually peaks around 48 hours after the burn.
Wow. Which is why urgent stabilization and getting fluids in is literally life-saving.
Absolutely. You always start with the primary survey, ABC. Airway, breathing, circulation. If the burns are anywhere near the mouth or nose, you have to suspect an airway injury, get them on 100% oxygen immediately.
Right.
Then fluid resuscitation, use crystalloids, usually ringer lactate, especially in the first 24 hours. And we rely heavily on those monitoring standards we talked about. Strict I&O, daily weights, and hitting that urine output target of at least 1 LNLO-GHR.
What about cleaning the burn itself?
First, stop the burning process. Get any smoldering or charred clothing off. Wash the area gently with mild soap and cool water.
Cool. Not cold or ice.
Correct. Never use ice. It
Yeah.
can cause more damage. Just cool water. And generally don't pop or remove blisters routinely. They actually provide a natural protective barrier.
Okay. And pain management. Burns are incredibly painful.
Yes. We use local anesthetics, systemic pain meds,
Yeah.
but don't forget non-pharmacological methods too. The source mentions using things like virtual reality games as a cognitive distraction during painful procedures like dressing changes. It can be really effective.
That's fascinating. And maybe the single most important prevention point parents need to know.
Set the home hot water heater temperature to 120 degrees Fahrenheit or lower. That's 49 degrees Celsius.
Why that specific temperature?
Because the time it takes to get a severe burn changes dramatically with temperature. Water at 150 degrees F, 65 C, can cause a third-degree burn in just 2 seconds.
2 seconds.
Yeah, but at 120 degrees F, 49 C, it takes about 5 minutes to cause that same severity of burn. That gives precious time to react and prevent serious injury.
Huge difference. Okay, let's wrap up. What are the absolute must-know takeaways for our listeners?
Okay, essentials for pediatric skincare. First, really internalize how fragile and permeable kids' skin is. That understanding underpins everything you do. Second, get good at identifying common lesions. Know the difference between that honey crust of impetigo and the ring-like scale of tinea. And third, for your really sick patients, especially burns, that fluid resuscitation goal 1 to 2 milliliter urine output, that's your critical non-negotiable target. Keep that number front and center.
Excellent recap. And finally, let's bring it back to the spacesuit idea. We talked about the challenges for teens like Emily dealing with visible psoriasis. When you think about the long haul for chronic conditions, eczema, severe acne, psoriasis, or even burn recovery that goes on for years, maybe the biggest, most consistent intervention you'll provide isn't a cream or a pill, it's that psychosocial support. The way these conditions look significantly impacts a child's or teen's developing identity, their self-image, their mental health. Understanding that struggle and supporting them through it is just as crucial as any physical treatment you offer. Thank you so much for joining us for this deep dive into pediatric tissue integrity. We really hope this insight helps you provide truly comprehensive and compassionate care in your practice.